the distinct pleasure of having a visiting professor around this morning. So I'm going to ask Dr. Mira Skandari to do the official welcome for Dr. Ian Clark. But I do want to just thank you for coming out to Toronto in January. When we're putting together a Grand Round schedule, it's not easy to think about who you're going to invite to Toronto in January. So naturally, you look to Winnipeg. And, you know, Dr. Ian Clark was telling me this morning that this is actually tropical for him. So I do want to thank you for making the effort. I also want to thank you for your years of work as a program director's chair. I came on just as he was finishing his term, and I quite admire your leadership and all that you've done for, you know, your program, but also nationally. So Dr. Clark has been instrumental in residency education and advocacy across this country. So we've all benefited from his work. John Lloyd, who's here as well, worked very closely with him for many years. So we're very, very privileged to have Dr. Clark here with us today. But I will ask Dr. Mira Skandari to do the official welcome.
All right. Good morning, everybody, again. And yes, I would like to formally invite our colleague for pediatric ophthalmology VPP rounds. As usual, he's a very modest man, so he says to keep this very brief, which I will do at his request. There's a lot to talk about, and he will, from his talk, you will see, but also his track record, as mentioned by Amandeep, is all about education. And so briefly, he's Cambridge trained and then did his residency in ophthalmology in Birmingham in England. So he's a fellow Brit trained, and then he's done 2 pediatric ophthalmology fellowships, the last one being at Sick Kids. And he, like some people, likes Canada, so he's here with us, and it's our pleasure to have him. As mentioned by Amandeep, he's been instrumental in returning residency to Manitoba, and he's been a great advocate for education all around. And we already know about ophthalmology, as mentioned, but one of his biggest achievements is having such a great support and leadership roles in both the Canadian and American orthoptic associations as well. And we have to remember that our colleagues and professionals in orthoptics are vital to ophthalmology, not just pediatric ophthalmology. And he's been an amazing supporter and educator on that field as well, which we should never forget about. He's going to tell us about how to make an eye. And I would like to welcome him so he has the full hour. Thank you.
Thank you very much. Okay. There we go. Okay, well, thank you, Dr. Rai and Dr. Mira Skandari, for the invitation to come back to the home of my... Okay. We've got a... Oh, I tell you what, maybe...
Yeah.
Yeah. That's this one here, isn't it?
Yeah. So fill that.
Fill that.
And then share screen.
And then we have to select.
Is it that one?
No, I tell you what, it's because I've got to restart the talk like this.
Is it
There we
showing?
go. Hang on, nearly. We're getting there.
Hang on.
Had something running earlier.
We did.
Why
don't we go?
Let's go back to PowerPoint here.
Yeah.
I've got. Shall I just exit this and
Sure.
And we'll close all of that,
Yeah.
and we'll reopen it.
Sure.
Okay. Sorry about this, everybody.
But yeah.
So I think go back to Zoom first.
Yeah.
Yeah, because I think you're on two screens.
So go back to Zoom.
Yep.
First, and then go share the screen on the bottom.
He's there, but the slides aren't showing up. That's the.
If I share screen first, maybe.
Don't close.
Okay.
No, share screen.
There's the
Bottom left?
power
Bottom
one.
left and optimize.
Above.
That one.
Yeah,
But that's going to show all the presenter
No,
notes.
no, it may not. Just go in.
Okay, so share that.
Yeah,
No.
and then go into your view. Yeah, that one. Yeah,
There you go.
Bingo. Okay.
okay.
All right. Sorry about that delay, folks. Right. Thank you very much for the invitation to come back to the Home of My Fellowship, everybody. It's a real honor to come and speak to you today on the topic of embryology.
So your new
Oh.
one is showing.
Okay. All right.
Oh,
So let's close this down. Let's. Okay, we're going to hit share screen.
no, the
Yep.
PowerPoint's not open. Hang on.
You can just get out of the present one with the text. Okay.
Back to Zoom.
Back to Zoom.
Why? Do share screen.
That was share
Oh,
screen.
that is share screen. Sorry. There it is. Let's see what happens. No, you have to go share screen from share screen. You went down. You're gonna help us? Sorry.
Perfect.
Thank you.
And go back to the share, Sandra.
Hmm?
Go back to the share.
So it wasn't highlighted.
So it's up.
And then man lawn. Da-da-da-da.
No. I think it's the view. Do you have to change the view?
So with Zoom, presenter mode always shows the.
Can we switch screens now?
Okay.
Oh, it's working?
It did work.
Did it work? Try again.
Had it working for a second.
Okay. All right. I'm not going to touch anything.
No, that's still not right
That's
now.
okay. Actually,
Okay.
Oh, it's
Not even present.
yeah.
okay. I'm gonna wing it without presenter mode. That's what we're gonna do. Slideshow. Slideshow. Right.
Perfect. Thank you.
Okay. Sorry about all of that. So I'm going to be talking about the embryology of the eye, and the reason that I'm picked this topic is that as pediatric ophthalmologists, we get to see the results of embryology that has gone wrong, and on top of that, it's a topic that I don't think that we've done a particularly good job historically of teaching our residents, and they were very candid to point that out to me. So so I thought I should step up and try and do a presentation on this topic. And it is something that we tend to learn, I feel, as a series of steps when you're reading through the books, and that can make it hard to sort of put the whole thing together and understand this incredibly complex process. So hopefully I'll be able to illustrate things for you and allow you to appreciate the steps in a more fluid manner. And I'm going to be using some of these slides on the right here. This is a picture from a mouse embryo atlas that's available online, which is an excellent resource. These are my other resources, and I have no financial interests to declare. So if we go back, okay, no, I've exited that. So if we go back right to the beginning, we obviously have the fertilization of the egg that produces a zygote. And the zygote undergoes division to form the blastocyst. I'm going to talk about all of these steps. The zygote is contained within a glycoprotein layer called the zona pellucida, which is very tough. So there's no space in there for actual growth at all. And what happens is that the cells undergo cleavage, and that's shown in this video here, where we can see the cells initially dividing into 2 cells and then 4 and so on until by about day 3, we have a process that's called compaction. So as you watch this video of a human embryo, you'll see that the cells, rather than forming a clump, they start to go to the periphery of the zona pellucida, and you end up with a blastocyst with a central cavity. Now, at this point, the zona pellucida is too restrictive, and so eventually the embryo will burst out from the zona pellucida, as you can see here. And at this point, it will implant in the endometrium. So that's at about 7 days. Now, by this time, we have the first differentiation within the embryo. So we have the trophoblast on the outside, which goes on to form the amnion and the placenta. But we have a clump of cells at one end of that that's called the inner cell mass. And that's shown here in this slide. So we have the trophoblast illustrated in red, and we have the inner cell mass, which now differentiates into 2 layers, epiblast here in blue and hypoblast underneath. And the hypoblast will divide and will cover the internal surface of the blastocele here, and that will go on to form the yolk sac. And this area here that's blue will cavitate, as shown in the right-hand diagram, and that forms the amniotic cavity. And these are the cells of the epiblast. So this process up until this kind of time is called blastulation, because it results in the formation of the blastocyst that we can see on the left. And now we move from there into gastrulation, which is the next stage in the development of the embryo. So gastrulation is the differential growth of cells to form a multi-layered gastrula from this step that we're at here. And so at day 13, we have the epiblast that is wrapped around the blastocele at this end, or the blastocyst at this end, and we have the yolk sac beneath. And what happens on day 14 is that we start to see differential growth in this layer. So if we look at the diagram beneath here, showing this bilaminar disc from the side, we get growth from the cranial end of this plate, and the cells migrate around on either side here towards the caudal end, and they disappear down beneath this layer in what is called the primitive streak, and the primitive node is at the end. So we've now defined the longitudinal axis of the embryo. And as these cells dive down, they displace all of the cells of the hypoblast. So these cells here are going to migrate down through the primitive streak, and they're going to completely displace the hypoblast and push them peripherally. And this layer will go on to differentiate into the endoderm. So when that has happened, the job of gastrulation is not complete, because we continue to see division of this layer of cells, and they continue to pass down through this primitive streak. But instead of displacing the cells beneath them, they now start to sandwich themselves between, and that will go on to form the mesoderm layer. And then the final part of gastrulation is where we get differentiation of the epiblast cells, and they will differentiate into the surface ectoderm. So we then end up with our triploblastic embryo, which is 3-layered, and we've got our surface ectoderm, we have our mesoderm and our endoderm, and this is common to all animal embryos, all embryos in the animal kingdom, apart from sponges and jellyfish, who have a diploblastic embryo. Of note here, the endoderm goes on to play no part whatsoever in ocular development. It goes on to develop the GI tract, lungs, pancreas, liver, organs like that, but there's no involvement in the eye itself. So this is a video which I hope will play that shows this is actually neural tube development, which I'll talk about in a moment, but it's a frog embryo, and the reason I wanted to show this is that you can see how the differential growth of these cells allows these processes to take place, and you can see the groove forming there and the neural tube starting to close over that groove, and it's a nice illustration of how this process is a fluid process, despite the steps that I'm describing. So here we're looking at a very early stage of embryogenesis. This is 25 days, if I just move John out the way a little bit there. So this is the developing forebrain, the telencephalic vesicle. And you can see that we have these little buds that are coming off here. So this is early development of the eye. This is the optic vesicle, and we're all familiar with this. You get this little blister effectively coming out of the telencephalon. This is the optic vesicle, still connected to the telencephalon via the optic stalk, which will go on to differentiate into the optic nerve. If we zoom in here, we can see that eventually we've got our surface ectoderm here. This is the neuroectoderm of the telencephalon. And these cells here are mesoderm. So the mesoderm here has been completely displaced and pushed to one side by the growing optic vesicle. And when the optic vesicle makes contact with the surface of the embryo, then two things happen. So the first thing is that we get the induction of the lens placode. So this surface ectoderm is going to go on to develop into the lens. But we also get induction of the surface ectoderm in this area, sorry, the neuroectoderm, which will go on to develop into the neural retina. And we'll see that process in a moment. What happens at this point is that we get invagination of these two layers. And so I think of this like having an inflated party balloon. And if you stick your fist into it, then your balloon shape starts to become cup shaped, and we end up with two layers. And we can see that here. This is a 28-day-old, equivalent of a 28-day-old human embryo. And at this point here, we can see we have the outer layer of the cup, which is thinner and is going to go on to develop into the retinal pigment epithelium. And we have the inner layer, which is thicker, and that is going to go to form our neurosensory retina. The lens pit is situated in this position, and that will continue to invaginate and eventually bud off completely from the surface. Now, the optic stalk is still connected to the telencephalon, and in embryogenesis, there's a complex interaction of pathways that are controlled by genes that that involves diffusible ligands that allows cells within the developing embryo to orientate themselves with respect to their location in the embryo. And it's these gradients of these diffusible ligands that will help ensure appropriate differentiation of these multi-potential cells. And so here in this process, the sonic hedgehog gene product is very important in differentiating the optic stalk from the tissue of the developing eye itself. And it's probably because of this differentiation that when you see cases of optic nerve hyperplasia, which can be devastating visually, it's usually not associated with any globe malformation at all. So moving forward to about 30 days here, we can see that we have our optic cup has deepened, the surface ectoderm has invaginated, and we're almost starting to see this area pinch off where the surface ectoderm has formed our thickening lens vesicle here. This is the lens placode. And these edges will eventually go on to meet, and this structure here will form a little vesicle. We're also seeing some mesoderm and neural crest cells. I'll talk about neural crest cells in a moment, migrating into this area here. But there's no mesoderm at all in this area between the two layers of the optic cup. And this is important because mesoderm goes on to develop into connective tissues. And we have no mesoderm at all between these two layers, the developing neurosensory retina and RPE. And that's why these layers remain easy to separate later in life, because there's nothing really other than electrostatic forces holding them together. So at this point now, we have our lens vesicle completely separated from the surface ectoderm. The surface ectoderm is going to go on to develop the skin of the eyelids and the meibomian glands, cilia and conjunctiva, and also, importantly, it'll form the corneal epithelium. Around the same time, we're developing our lacrimal drainage system, and there's a cord of tissue that develops in this area that I'm trying to remember the name of it now without my notes. The frontonasal process, I believe it's called, and that cord of tissue will canalize and form the lacrimal drainage system. And if you get a failure of that process to occur, then we can see fistulae and pits, such as in this kind of clinical photograph. So I'm going to just show this video, zoom forward in it a little bit. I tried to get our anatomy department to give me some more professional looking videos, but YouTube got the answers. So this shows this process up to this point in a chicken embryo. And you can see these the buds off the forebrain. We've now got thickening of the lens placode and the neurosensory retina beneath. And you can see here in the video that the invagination as these structures dip in and the lens starts to bud off. Okay. So at this point in the development of the embryo, we've now can see that there is some tissues here behind the lens vesicle. We have the vesicle as well developed. We're starting to see some lengthening of the cells in the posterior aspect of the lens vesicle, which is important for development of the lens. And we have this mesoderm here that has arrived within the optic cup. And this is going to form the vascular supply to the developing lens called the tunica vasculosa lentis, amongst other structures. So how does this tissue get into an optic cup? Because if you think of that party balloon analogy, then it's hard to understand. But what happens is that the growth of the optic cup is not quite as straightforward as you might imagine. It's not as straightforward as that. And you obviously have this fissure that we're all familiar with. And so this fissure here allows entry of mesoderm and neural crest cells into the posterior segment so that they can contribute to the structures that they form there, which include the tunica vasculosa lentis, the blood supply to the retina that we all see when we're doing fundoscopy, and the primary, secondary, and tertiary vitreous. Closure of the embryonic fissure takes place from its center and radiates or moves anteriorly and posteriorly at the same time, like a zipper. It's very uncommon to see a failure in the center of the fissure, but it's really not that uncommon for us to see colobomas. And these are defects in the fissure closure posteriorly or anteriorly. So these are varying degrees of colobomas seen in the posterior segment. A little more commonly, we see anterior segment colobomas. And this is obviously an iris defect. And they're always, whether they're anterior or posterior, they're always in the same location, which is in this sort of infranasal location, which is very characteristic. Okay, so moving on to day 44, things have obviously progressed further. We've got now the developing eyelids. You can start to see forming here, above and below the eye. We've got some pigment appearing in the posterior optic cup. You can see there's some melanin forming in there. We've got a much thicker neurosensory retina, which will, by about 8 weeks, start to differentiate into different retinal layers. We can see that we've got here developing vessels within our tunica vasculosa lentis starting to grow. The lens posterior fibers that I said were starting to elongate have now grown so much that they've completely obliterated the space in the lens vesicle. We still have this single layer of cuboidal cells on the anterior surface of the lens. And the lens secretes its own basement membrane, and it's unique in the body in that respect because it actually envelops itself completely in its own basement membrane, and there's no other structure in the body that does that. That's obviously, it's not a trivial fact, because that's why if we breach the lens capsule and allow the lens contents to leak out, that we get an immune response, because the developing immune system is never exposed to these lens proteins. We can also see in this slide the developing mesoderm within the orbit. So this area here, you can see, is going to start to form the extraocular muscles. Developing muscles need to have appropriate innervation. So if you don't have innervation going to these muscles that is working the way that it should, then this mesoderm doesn't know how to differentiate. And what it will tend to do is it will tend to go on to differentiate into connective tissues. And so that explains why when we see and operate on patients like this, who has a congenital ptosis, then we often see fibrosis and fatty infiltration of the muscle, because it is continued down a developmental pathway that it shouldn't have. Also on the topic of the extraocular muscles, the way that these muscles develop helps us understand the innervation. So the superior oblique and lateral rectus will develop in areas that are distinct from the muscles that end up supplied by the third cranial nerve. So that helps us understand the innervation of these muscles and why it arises the way that it does. And speaking of congenital ptosis, then we often see clinically that these patients have limited upgaze. And that makes perfect sense when you understand that the levator pulpari superioris develops from the same block of tissue as the superior rectus. So if you have a problem with one congenital ptosis, then often the superior rectus is not working properly as well. And the cranial nerves, incidentally, are derived from ectoderm and neural crest cells. We've talked mostly about this slide, I think, so I'll move on to one of my digressions. So in Charles Darwin's book on the origin of species, he wrote, as I'm sure many of you are aware, that to suppose that the eye with all its inimitable contrivances could have been formed by natural selection seems, I freely confess, absurd in the highest degree. So he dedicates an entire chapter in his book on problems that he perceived with his theory of natural selection. So one of the things that troubled him was that when he looked at the structures of the eye and the complexity of the eye, it was hard for him to wrap his head around how that could possibly have happened through sort of chance mutations. Well, it turns out that we don't really have to look too far to try and understand how this could have evolved, how an eye like ours, what is termed a camera eye, could have evolved. Because if we look just at the phylum of mollusks, then we can see many different types of eye that help us appreciate the steps that were probably taken. So if we start off with just a simple patch of light-sensitive cells, this would potentially confer an evolutionary advantage to that organism. An organism like this would be able to develop a diurnal rhythm. It would be able to orientate itself in its ocean, so it knows which way up it is because of the light above from the sun or the moon. It might be able to sense the shadow of a predator coming and make some attempt to escape. And so it's understandable how that could help this organism survive and pass on its genes. But if we then take that same patch of light-sensitive cells and we just put it into a little dip, then that's going to give you a little bit more orientational information. So as that predator passes across, you'll see the shadow passing across the cup in a differential manner, and then that organism may have a better idea of which way they need to go when they're trying to escape a predator. And bear in mind that the predator that's predating on them is not going to have sight, because at this stage organisms were really sensing their environment through smell and through touch. So if we were to move forward a little bit and deepen the cup and form some sort of a pupil over it, well, we're now getting something that looks a little bit like a pinhole camera. And this is going to be able to create a much clearer image on the surface of what's going to form a retina. But the problem with this arrangement, and this is seen in the nautilus, is that they have no humor in their eye. Their eye is open to the ocean, and debris could collect in there, or another organism may decide that it makes a nice safe habitat in which to live. And so that's not really an ideal solution. And what would be better still would be if you were to have some sort of transparent cover over the surface of it. This whole process that I'm describing is really, I think, very much resembling what we have been talking about in human embryology with this stage here looking a bit like the surface ectoderm, which is induced, and so on and so forth. And so it was because of the similarities with other organisms that this German academic Ernst Haeckel in the 1820s proposed his theory. It's just a theory called the recapitulation theory, in which he said that ontogeny recapitulates phylogeny. So if we look at the human embryo, the stages of the human embryo, it very much looks similar to other lower animals lower in the animal kingdom. But this is, at the end of the day, just a theory. So in terms of supporting Darwin's theory of natural selection, it's really very telling that within vertebrates and cephalopods that we see eyes that in terms of their structure are so very similar in many respects. If we look at an octopus, they have a pupil, they have a lens, they have zonules. Their retina is very similar to ours in structure, but the thing that's remarkable is that their retina is completely inverted compared to ours. So it also uses a different class of opsins. And its photoreceptors, as you can see here, are not located against the RPE, but they're facing towards the pupil. And clearly, that's not something that's going to happen by chance. You're not going to have a point mutation in this invertebrate that suddenly flips their retina around. The answer is that this is an example of convergent evolution. So we have two different species that have evolved a very similar solution to the same problem, that of trying to acquire good eyesight. And they've done so down completely different evolutionary pathways, which reinforces this, rather than creating problems for Darwin's theory, it really reinforces it. And what was that evolutionary pressure? Well, it was probably carnivory. So we know that that early single-celled organisms would consume each other. If they could touch them, you could ingest other organisms. But it was really only when eyesight started to develop that we see meat eating hit the big time. Okay, so being able to detect your prey from further away than you're able to smell or touch them is a huge advantage. And that probably explains why, or is one of the theories at least, why we see this explosion of development of species in what's called in the Cambrian period, and it's called the Cambrian explosion. So this graphic here is a really lovely illustration of all of the species that are seen on the planet. So we have bacteria down here on the left, and if we go all the way around, we go through plants and fungi, and we have mammals over here with humans at this side. Back here is the birth of the Earth about 4.5 billion years ago, and then time is radiating out in all directions. So if we look here as we follow through time, we've got sort of about 3.5 billion years of really not very much happening. We've got very primitive organisms, but then at this point here, the Cambrian period, we see this huge increase in diversity. And there are many theories. It might be to do with the composition of the oceans, it might be to do with the climate at the time, but one very powerful theory is that of sight. And when organisms developed an ability to see their prey, they were able to eat a much richer diet and gain a lot more energy. And this produced a huge amount of evolutionary pressure, and what you could think of as like an evolutionary arms race to develop better vision, to be able to better predate, but also to escape. And it resulted in the development of faster movement, longer limbs, armor, and so on and so forth, that resulted in this big diversity in species. Another question that was raised about the evolution of an eye is, if our eyes, if a camera style eye like we have, is so good, then why on earth doesn't everyone have a camera style eye? If the evolutionary advantage of having an eye like ours is so high, then why are there so many diverse types of eyes in the animal kingdom? And the answer to that is probably the fact that these animals have evolved in their own environments with their own evolutionary pressures. And so they've all taken their own different pathways to get to where they need to go. And if you were to take a human style eye and stick it in a fish, well, it's not going to see, obviously, the same way we do. You need a very complicated central nervous system to be able to process the information that can be seen. This comes back to sort of amblyopia. If you suddenly make a kid aware of the fact that they have an eye that they've been ignoring all their life, then the vision doesn't suddenly improve. So organisms evolved eyes that suited what they need according to their environments and their needs. And once they'd acquired vision that was suitable for that purpose, then there was no evolutionary pressure to go on to develop a more complicated eye. Okay, so back to our human embryology. We can see here our lens, our developing vascular supply here. The reason I pulled this slide up is that at the top of the image, we can see the surface ectoderm, which is forming our corneal epithelium. And we're beginning to see a lot more cellularity in this area here. So this is down to migration of neural crest cells. I'm going to talk about those in a moment. But the neural crest cells come in 3 different waves. The first wave comes across and forms the corneal endothelium. We then have a second wave that comes in and finds its way to the anterior surface of the optic cup. And that's going to form the anterior iris stroma. And then we have a third wave that sandwiches itself between the endothelium and the epithelium, and that's going to form the stroma of the cornea. When this process goes wrong, it's easy to understand, like in Peter's anomaly, how we can end up with these adhesions between either the lens or the iris and the posterior surface of the cornea, because embryologically they're all intimately connected. So the tunica vasculosa lentis is developing from the mesoderm, and the reason why it develops is that even though our lenses are avascular, at this stage in embryogenesis, the developing lens has a very high metabolic demand, and so it needs a rich blood supply. There's no venous drainage of this arterial supply. The drainage is all through the choroidal plexus. And the photograph on the right is something that not many of you may have seen, but for pediatric ophthalmologists who go up to NICU to see babies, then we can actually see this embryology in vivo in these very preterm infants. So here is an infant with a persistent tunica, as we might see on NICU. When the tunica fails to regress, as it should in everybody, we see some remnants in some patients. And this could be anything from a mild persistent pupillary membrane, like this image at the top. It can be more extensive, like this image down here. And at the other end of the scale, you can get persistent fetal vasculature, where you can see a microphthalmic eye with traction on the ciliary body. And if you see traction at the posterior segment like this, this is normally very bad news for the child's visual potential. Of note, it's very easy, it's important to realize that these are not posterior synechiae. So when you see this type of appearance, I hope you can see that the iris tissue that's attached to the anterior surface of the lens is coming from the collarette. And that's because that's where these vessels are from. They arise from that area. When you can see it down here as well. It's not the pupil margin that is stuck down, but it's sort of the mid iris where the collarette is. That's where the vessels are arising from. Okay, so we're now day 15 and a half. I didn't put the date up there for the human embryo, but at this stage here, we can see the thickening of the neurosensory retina. We still have this pigmented tissue here, which is our developing retinal pigment epithelium, and the lids are forming a little bit better. The lids will go on to fuse and completely cover the eye. And you may think that's odd, but in the animal kingdom, it's not uncommon for a fetus to be born like this mouse here, with their eyes completely sealed closed. It takes about 2 weeks for a mouse to actually open up its eyelids. We don't see this very commonly in human infants, but you can see varying degrees of this. So this image on the left is called, this condition is known ankyloblepharon, and there's just a tiny little strand that's still connecting the upper and lower lid. And that won't have any pain fibers in it or anything, so it's very easy to just divide that with a pair of Vanna scissors in the clinic. And then obviously at the other end of the spectrum, we have this infant here in the center who has Manitoba oculotrichoanal syndrome, motor syndrome, where there's complete cryptophthalmos, and you know, the hairline comes down low and there's really no lid structures that are detectable at all. Okay, so I've been mentioning these elusive neural crest cells, but I haven't really explained anything about them, so I'm going to try and do that for you now. They are obviously, as this diagram shows, widely distributed through the body. We have them divided up into 5 different types. We've got the cranial, cardiac, vagal, truncal, and sacral, and they go on to form much of the peripheral nervous system. So they arise through the process of neurulation. So we've talked about blastulation, gastrulation. This is neurulation now. So again, we're going back to an early embryo here. We've got our primitive streak and our primitive node. And then at the cranial end of this embryo, we're going to see in the mesoderm this structure called the notochord forming. And the notochord will induce the formation of the neural ectoderm in its overlying area, which we can see here with these purple cells. So we have the surface ectoderm here in blue, and neural ectoderm here. And as we progress through neurulation, we start to see the cells at the edge of the neural plate differentiate into the neural crest cells. And they're called neural crest cells because what will happen is that that neural plate will invaginate, as I showed in that video of the frog embryo. And at the crest of that that structure, as it's starting to invaginate, are these cells which are shown in green that go on to form the neural crest cells. So they undergo an ectodermal to mesenchymal transformation. And as they are completely internalized, as shown in this image here, we've now got the surface ectoderm completely covering the neural tube. They will delaminate, and delamination is a process that allows them to separate from one another rather than being an adherent clump of cells. And they undergo these stereotypical waves of migration, like I described, where they'll head off to different parts of the body, providing this important cell type to develop into these various structures, which we'll talk about. And here is this stage in a human embryo. We've got the anterior neuropore here, and we've got the posterior neuropore here, which will close at about day 24 and 26. And here the neural tube has closed off in its center, and that is where the neural crest cells will start their migration. When neurulation goes wrong, we can see some fairly dramatic consequences. So this diagram to the right shows the neural plate, and it's very important that this is lateralized, that you basically divide it into a right and a left half. And if that fails to happen, then we can see serious consequences. So within the neural plate is the frontal eye field. And there are various genes that are involved in this, including the sonic hedgehog gene and the SOX3 gene, or sorry, 6-3 gene. And the ligands produced by these genes are important for differentiating the right and left frontal eye fields. And if we don't see that happening, then we can end up with this condition known as cyclopia. Whilst that's very severe and very rare, I've certainly never seen a case. We can see milder degrees of problems that really severely affect globe development. In particular, SOX3 is a gene that is implicated in cases of microphthalmia and or anophthalmia. So it's appropriate that I'm showing this image. I'm showing this because it is an image that is related to neural crest cells. So it's a case report. That's why it's a slightly grainy picture from a case that was treated at the Hospital for Sick Children here in Toronto about 30 years ago. You might look at this and think that there's a blue-eyed patient with a sector iris nevus, but unfortunately this child was in the hospital because of an acute abdomen, and the cause of her acute abdomen was a neurocrystopathy. So neurocrystopathies are diseases that are all linked back to problems with neural crest cells. So this can be a problem with expression of neural crest cells, of migration, differentiation, or abnormal apoptosis of neural crest cells. And so in this particular case, the problem was not just with the eye, but it was also with her gut. And she had Hirschsprung disease, which is due to a failure of sacral neural crest cell migration, resulting in a section of aganglionic and non-motile gut. And the histology slides on the right are interesting because you can see here these two. This slide here is a section taken through the brown part of the iris, which is the normal tissue. And you can see in here we've got pigment cells because neural crest cells give rise to the pigment in the body. Whereas if we look over on the left-hand slide, we can see that there's no pigment in the iris stroma. It's hyperplastic. You may well be asking, well, why have we got pigment here? This is black. There's so much pigment here. Well, remember that the optic cup produces the retinal pigment epithelium, and that is the only tissue that is not derived from neural crest cells in the body that will produce any pigment at all. So that explains why the posterior pigmented iris epithelium is normal in this case. So I'm only mentioning neural crest cells quite late in the game, but you can see that they produce a huge variety of tissues in the eye and the orbit and surrounding structures. This graphic's taken from the manual, and they've colored the neural crest cells in this sort of teal color. but we see that they go on to form the sclera and all of these structures that are listed on the left. And they also form a lot of the facial skeleton. And so if you see problems that arise in neural crest cells, then often you get these syndromic type of pictures where you get abnormalities that not only involve the face, but also the eye. And one such example is Axenfeld-Rieger. Axenfeld-Rieger, where we can see maxillary hyperplasia and we can see dental abnormalities, and those are all derived from neural crest cells, as well as the features that we're familiar with the eyes, such as the posterior embryotoxin here with adherent iris strands. We can see pseudopolychoria, and here we've got anterior iris stromal atrophy. And glaucoma is obviously a feature in this condition for many individuals. And again, that makes perfect sense because the trabecular meshwork is derived from neural crest cells. So talking about neurocrestopathies for a moment, some people have proposed that you can divide these conditions up into 3 different types: dysgenetic, neoplastic, and then mixed. So you can see here what a wide variety of pathologies you can see related to neural crest cells. So we've talked about Hirschsprung disease, but the craniofacial malformations are thought to be related to neural crest cell problems. We've mentioned congenital cranial disinnervation disorders, Charge syndrome, and Goldenhaar syndrome. These are all examples of dysgenetic problems. Neoplastic neurocrestopathies include neuroblastoma and pheochromocytoma. And then we have down here all of the neurocutaneous syndromes, so von Hippel-Lindau, tuberous sclerosis, Sturge-Weber, and so on. They're all thought to be neural crest cell derived in terms of their pathogenesis. So I'm going to finish off now with a case that I just wanted to describe. This is a clinical photograph of a boy who presented as a 2-year-old with reduced vision in one eye. And for reasons that aren't entirely clear to me now, but at the time they weren't sure what was going on. This was a surprise to the family. His fundus obviously shows this significant traction temporally. And around the time that this boy was being worked up, the mum had her second child. And after about 7 weeks, the mum thought, things don't look great with this kid. I'm not sure she's seeing so well. And when she was examined, unfortunately, she had bilateral tractional retinal detachments with what looked like a sort of what people historically described as retrolental fibroplasia. Subsequent to that, the family moved to Manitoba and still didn't seem, when I met them for the first time, to have much of an idea of what was causing this problem. They were very accepting of it. But mum told me, oh, I'm pregnant and I'm, going to have a baby. And I'm thinking, I don't want this baby to be blind in both eyes. So obviously in a situation like this, you take a family history, and we've obviously, as I described, we've got the brother here who is monocular. We have a blind sister for this as yet to be born baby. Dad was completely asymptomatic, but when you delve back in the history, not very far, we find that we've got his mother and his grandmother were blind in both eyes. You do want, in pediatric ophthalmology, when you see something unusual like this, to try and examine all available family members and consider this pedigree. And it looks like it's likely to be autosomal dominant. And my feelings were that this might be something along the familial exudative vitreous retinopathy spectrum. So I called a friend. Joanne Robitaille is a wonderful pediatric ophthalmologist in Dalhousie with a research interest in this field. And as soon as I started to talk about this family, she goes, oh, yeah, I know him. Yeah, these people, yeah, familial exudative vitreous retinopathy is what they have. So it didn't take long to get an answer as to what was going on. But the problem still remained as, what are we going to do for this unborn infant? So I spoke with her, and I spoke with Wai-Ching Lam, and I spoke with other trusted colleagues, and we spoke with the obstetrician because we needed to confirm whether this child had the familial mutation. And the family were not considering a termination of the pregnancy, so we could delay the amniocentesis to a time where one of the main complications would be a premature delivery. And if a baby's born at 29 weeks, then that would almost certainly survive. So we could defer the amniocentesis to get confirmation of whether this child was going to have the mutation. And he did. So it was positive. And so then the decision is, well, what are we going to do next? And inducing early delivery is obviously entirely possible, but there are associated risks with that. But a birth at 36 weeks should really have the obstetrician reassured me that, that kid probably wouldn't even need to stay in overnight, that these days that they're very confident that the outcome would be great. So we induced the baby at 36 weeks. Obviously, delaying it further would be safer, but then I was concerned that the child may detach in utero. We really didn't know, and there's very little literature on this to help support a plan. So we all felt comfortable with 36 weeks, and so that's what we did. And then I had a look at the child the following day. So thankfully, attached, normal looking posterior pulse. So this is, day one. But if we look into the periphery, I don't know how well it projects for the right eye there, but this looked like an immature retina in retinopathy of prematurity, even though this baby had a good birth weight and should not have had ROP. So we have avascular retina in this area, but really no demarcation line or anything like that. However, in the other eye, we can see these hemorrhages that are reminiscent of the type of hemorrhages you might see with very posterior ROP. And we've got some fibrovascular changes, and this is clearly avascular in this area. And that finding is supported by fluorescein angiography, and Dr. Tarani is anxiously waving her hand.
As you're showing for retina on that right side. What's
Yeah.
the nasal section?
Right off the top of my head, I don't think it was fully vascularized. I think it was the same type of picture.
36 weeks.
You would, absolutely. But clearly we have, as we'll talk about, a failure of retinal angiogenesis in this case. So as always, these produce really beautiful fluorescein angiography pictures, but it clearly shows the ischemia in both eyes, even though it's harder to see in the right. So familial exudative vitreoretinopathy results in a premature arrest of retinal angiogenesis and vascular differentiation. So the process that is occurring here is that the Wnt signaling pathway is critical for this process to occur naturally. The Wnt signaling pathway is a pathway that controls cellular differentiation in a dizzying array of, it's very well preserved, like homeobox genes. It's something that's seen throughout the animal kingdom. And when it goes wrong, you can see conditions that are as varied as breast cancer to spina bifida. And in this case, the Wnt pathway is important for retinal vascular development. And we know in this condition that the Norrin ligand, the gene product of the Norrin gene, binds to the Frizzled-4 gene receptor, and that is what activates the Wnt signaling pathway. It's typically, when autosomal dominant, very variable. So we've seen in this pedigree alone, we've got dad who's asymptomatic, and we have one child with tractional retinal detachments in both eyes. And then obviously we can see neovascularization, vitreous hemorrhage, retinal exudates, and so on and so forth. Because these pathways obviously share many genes that control them, you can have other genes that I've listed down here that have been implicated in its pathogenesis. So it's not unique to the FZD4 gene. And there are X-linked and autosomal recessive inheritance patterns that are also documented that tend to be much more severe and are thankfully less common. So this is my last slide. I've obviously followed this kid. We've been doing serial EUAs. After speaking with my colleagues and getting advice, we decided the best way to treat this kid was not with injections, but to old school laser and to ablate the avascular peripheral retina, so this is, I think, after the first session of laser. The child is now nearly a year old and is thankfully still attached. My laser has likely induced some anisometropia, so I've got the child in glasses at this point to try and make sure we continue to see good vision in both eyes. But so far so good for this kid. Okay, so that concludes my tour. I hope you enjoyed it. I hope it made embryology make a little bit more sense for all of you, because it's can be a pretty dry topic when you're reading it in a manual. These are my references. I'd be happy to answer any questions. Dr. Tarani again.
So what is the dad's eye exemption.
So, yes, he has been investigated. He's been looked at. I can't remember off the top of my head. I'm not going to lie to you and tell you that, oh, he's looked fine. But certainly he's not required any laser or anything like that. He has been seen by one of our local retinal specialists. So I assume that there's nothing there that needed any treatment.
So they asymptomatic, but he must have probably has something.
Well, it's very variable. So I'm sure, but there was nothing that needed any treatment because he's never had any treatment. And I'm absolutely sure that if he had patches of ischemia, then he would have got some laser to that.
Because I mean, I think the fluorescein mentioned it's not just
Yes.
look
Oh, yes.
clinic.
Yeah, absolutely. Yeah, agreed entirely. Yeah.
Thank you. Imagine what you've done. You've saved that child.
Well, that's why it's great to be a pediatric ophthalmologist.
Isn't it?
You can make a lifelong impact on these patients. Yeah, let's hope it stays. I mean, you can't be overly confident, but certainly the family and I are very happy. This is something that I think we need to publish to show that if you can identify these cases, we're in an era of molecular medicine, and so we can make diagnoses like this, and hopefully make a real difference.
Well, Ian, thank you. Oh,
The 3 questions.
no, those are just
Okay.
me sharing the evaluation link.
Okay.
Well, thank you, Ian, for a fascinating talk. And he's staying on to do resident teaching. So again, thank you for making the effort for us. And I was thinking exactly what you were saying, Dr. Tarani. Like, this case was incredible because you've forever changed this kid's life, right? Like there was an outcome that could have been awful, and this child may have a totally normal life. Some anisometropia, we can manage that, but what this child is going to be able to do for the rest of their lives has forever changed due to your care. So that's incredible. That's the impact of the work that pediatric ophthalmologists do. And you made this topic very enlightening. I think, it's nice to have a review of embryology. I see the residents nodding, the OCAP's coming up. So I hope that helps you guys. But thank you for making the effort to come out to join us this morning. And I'll see, we're going to end the grand rounds here. So I'll see everyone next week. Bye. That was a very cool case.
Yeah.
Fascinating.
Wow.